Hi, I'm Michael Summer. I'll be giving a quick in-service on patient protection. We're going to go over a few topics such as confidentiality, informed consent, advanced directives, and right to refuse care. When it comes to confidentiality, we have the Health Insurance Portability and Accountability Act, first enacted in 1996. It was then revised in 2003, and like it says, in the 96 one said that all patient information is deemed confidential and private, and we need to do our best to protect that, including anything that involves transfer of medical information, anything involving their insurance or payment and financial agreements. That's all to be kept private. It was revised in 2003 with the privacy rule, which gives healthcare providers a little bit of protection when it comes to transferring that information. An example being if a nurse and doctor are inside a nurse station and they're doing their best to keep that information private, and it is overheard by a family member or something, that law gives them a little bit of protection that they were in a healthcare setting and not fraudulently distributing that information. For informed consents, we have the Patient Bill of Rights that was adopted by the American Hospital Association. It was created to protect patients and their rights, to educate on procedures and alternatives, and lastly, to obtain consent prior to any treatment. As nurses, we are charged with obtaining consents more than any other person inside of the acute care setting. So I'm going to go over a few things to try to prevent any of the pitfalls or hurdles and obstacles that we have with obtaining consent. First of all, who can give consent? That would be the patient, a proxy, which is someone who is deemed to be able to consent for a patient that is not competent due to the current medical condition, or by a surrogate for people that have mental incapacity to do so, or that are minors. Types of consents are written, which is what you would obtain for a vast majority of procedures, especially the invasive procedures. You have verbal if you're trying to draw some blood or start an IV, and you ask the patient if you can start an IV on them. They say yes, that's an appropriate verbal consent. Then you have implied. If the patient presents themselves to the ER for treatment, it's implied that they want their temperature taken, vital signs, and things like that. You also have V versus West Brookshire Health Authority, and that deals with patients that present themselves to the ER maybe after a motor accident and they're unconscious, that you presume that they want treatment. How can you deem someone to be competent? You can do two very quick methods. You got the mini mental exam, and you can assess them for alertness and orientation by person, place, and time. When it comes to consent, you want to make sure that the patient has the appropriate knowledge base. And a study was done where parents signed their infants up for a NICU research program, and they did 6 months later they did a quick interview and found the vast majority of the parents did not know that children were going to be subjects of research. So we want to improve them by using the common rule, and that's going to help with them so that they would understand all the areas that needed to be covered prior to consenting for a procedure. This is going to, especially when it comes to research, this is going to declare what the research is, the criteria, and all the procedures that are going to be involved. It's going to educate on risks and benefits. It's going to identify any alternatives to treatment. It's going to explain that all information is confidential, and that they are volunteer and they can withdraw from the research at any time. And when you do it, when you've covered all those areas, hopefully you've reached enough information that you can deem that person competent, and they use what they call the reasonable person rule. And that's if the information you've given the patient has any reasonable person will find that information if they are competent to be able to make a good informed decision on their health care. So you have the right to refuse care, and just like the patient has the right to consent and the right to make informed decisions on the treatment, if they had the capability, they inherently had the same right to refuse care, including medications, treatments, even life-saving measures such as simple hydration. And that was covered under the Cruise-On Director versus the Missouri Department of Health. With advanced directives, it's also known as power of attorney, and that allows an individual or a grantor to name a person or an agent to make decisions if they become incapacitated. Before they make that, you want to check their capacity level, and that is one's mental ability to make informed decisions. So your medical considerations for power of attorney, that should be made when the grantor is lucid mind, not under any kind of physical or mental or emotional duress. The grantor needs to know that they do not relinquish their rights at the time of signing, only once they become incapacitated. If they regain their capacity and their faculties, they resume their right to make their own decisions. They do not relinquish that right forever. And I consider that the power of attorney, do they want unlimited authority or restricted authority in decision making? And do they want it over just a certain area or multiple topics? And the Texas Advanced Directive Act, that gives healthcare providers an avenue of approach if the patient's agent that's making the decisions is prolonging health care, even if it's deemed futile. And if that is becoming non-productive, dangerous, and causing more harm, then that gives healthcare providers a little bit of leeway in addressing that. Like I said, I'd like to thank y'all for your time, and this is going to conclude our in-service. Thank you.